This is Dr. Chad Edwards, and you are listening to podcast number 10 of Against the Grain.
Welcome to Against the Grain podcast with Dr. Chad Edwards, where he challenges the status quo when it comes to medicine. We get into hot topics in the medical field with real stories from real patients to help you on your way to a healthy lifestyle. Get ready, because we're about to go Against the Grain.
This is Brian Wilkes here with the Dr. Chad Edwards.
Good afternoon, Brian. How are you today?
Good to see your beautiful face again.
It's good to be seen.
It's good. It's good. Neither one of us can be seen.
That's probably true.
I'm in shorts, oddly shaved, facial hair, and you seem clean cut today, though. Seem like you're on your A game.
I try to at least act professional.
You look like a doctor. You really do.
I play one on TV.
Hey, think like a proton and stay positive, big guy. Okay? This whole show, I need you A game today because we got a big issue, right?
That's the cheesiest thing I've heard all day.
I love it. I love it. So let's talk about our sponsors who are probably going to drop us right after the show.
Revolution Health and Wellness Clinic. We are, one of our big focuses is on bioidentical hormones, helping people to feel their best regardless of the source. We want to dig down and find out why you feel bad, addressing your musculoskeletal pains. So knee pain, back pain, neck pain, shoulder pain, all of those things. Sports injuries with prolotherapy, PRP, and stem cell therapies. Give us a call at 918-935-3636, or you can visit us on our website at revolutionhealth.org.
All right. Upper Cervical Health Centers. Upper Cervical Health Center is not your typical chiropractic office, different in that they never jerk, twist, snap, or crack your spine. They offer a gentle approach to address your health issues naturally. Their patients report an overall improvement, not just with their spine, of 75% in their health. You can call them at 918-742-2300 or visit their website at www.uppercervicaltulsa.com/new-you.
They're awesome.
Yep. Chad, how many MRIs have you had in your life?
I've had one, actually.
Really?
Yeah.
Was it during your service?
It was.
Okay.
Yep. And that, in the military, sometimes we do kind of this executive medicine thing because we're taking care of our assets.
Right.
We're
taking care of your assets. Is that what you said?
Yeah, taking care of your assets.
Okay.
Yeah, that's what I
thought you said.
So sometimes you have to, know what it is that you're dealing with.
Right.
Can this person deploy? Are you going to? Do they have an issue that's going to be covered by health insurance?
Right.
Are you going to be covering that issue? Is it a disability kind of issue? So sometimes we get a little more MRIs than we normally would because to answer some of those issues.
Yeah.
So I actually had one because of some foot pain that I got when I was deployed in Iraq, and I was running on gravel a lot at the time. And they said I actually broke a sesamoid bone in my left foot, little bitty bone. And interestingly, I never took more than a week off running, so I didn't really know how I did that. But got an MRI, and they said, yep, that's in two different spots. And then I went back and looked at an old x-ray that I had from the early 1990s and found out that bone was like that way back then.
Right. I've had one MRI. They discovered I had no brain. Are you surprised?
That's not surprising, Brian. I didn't need an MRI for that one.
There's that. But, hey, the truth of the matter is it seems like doctors are MRI happy. They love the old MRI. The question is it a great tool or not?
Well, I would say that it can be a great tool, but I would say that getting MRIs is kind of like picking your nose in public.
Oh, I like that analogy. Yeah.
What are you going to do with the results?
That's disgusting.
The
thing about doctors, especially when you do a show with a doctor, the things they talk about.
Hey, you said the doctors couldn't be funny, and I said challenge accepted. So
not on this podcast. And we're going to edit that out.
No, success. That was success.
Because that's not a fact, right? It's not. We're only about facts here on this show, right? So let's talk about some facts.
Let's do that.
Is an MRI actually a roadmap for surgery? So it seems to me, at least from the outsiders, again, I'm just a business guy, right?
Yeah.
I don't know anything necessarily to any degree about the medical industry. It seems like to me, you got something wrong, especially like, you talked about a foot injury with a little bone or whatever the case is. The path is you get MRI, then you get surgery, and then you're good, right?
That's the hope.
That's the roadmap, right?
Right.
So talk about that.
So basically, I'm a primary care physician, board certified in family medicine. When I went through my residency, of course, I was dealing with a lot of athletes, athletic trainer in college. I was in special operations for several years, and these guys are like Olympic level athletes. in the special operations realm, and they would have. Well, when I was in residency, I was preparing to go out and do some of these
Right.
things, and I knew that musculoskeletal conditions were going to be musculoskeletal
Right.
conditions were going to be way up on what I was going to see a lot. I wanted to get some extra training in that so that I could be competent and confident that I could take care of their issues.
Man,
so
you are just rolling out the big words
you
today.
like that?
Wow.
Well, I
Hey,
slept
everybody.
at the Holiday Inn Express last night.
Hey, right. This guy is going to doctor it up the whole show. I like it. Bringing your A game. I told you. Bring it. Let's do it.
Challenge accepted.
Challenge
So
accepted.
So I did some extra orthopedics rotations, and
Right.
my thought process was I want to spend more time with the orthopedic surgeon because I saw them as the pinnacle of understanding musculoskeletal conditions.
Right.
Now, not to disrespect any of them, because I've got some fantastic friends that are orthopedic surgeons, but what I found is that their emphasis was on identifying if there was a surgical issue or not. They did not do the clinical stuff, the outpatient stuff, the non-surgical stuff. They would look at it and see if it was surgery related, and this may have to do with the fact that it was military. I don't know that. But we had what we called ortho PAs, orthopedic PA physician assistants, and
Right.
they were the ones that ran the clinics. And what I discovered is that I wanted to spend all my time with those guys because I'm not an orthopedic surgeon. I wasn't going to go do orthopedic surgery and knee replacements and hip
Right.
replacements and all
Right.
these things. So it didn't make sense that I learned how to do those things.
Right.
If somebody needs that, I need to appropriately funnel them to those guys
Sure.
so that they can get them fixed in the most appropriate way. But what I wanted was the clinical stuff. And then as I spent time with them, there were some, you do like valgus stress testing. It's you angle the knee and
Right.
are these ligaments intact? And we did that as athletic trainers in college, and we can pick some things up with that. But patients will come in, they've got an injury, they've got pain, whatever it is, and they'll say, something's wrong with me, I need to get this fixed.
Right.
And so I, as a primary care doc, depending on my training,
Right.
on what level of athletic mentality or athletic training that I've had, or evaluating in the sports medicine realm, will kind of dictate the path that patient goes on. If I don't spend much time with the patient, don't do a thorough physical exam,
Right.
then and I can even do a thorough physical exam. I can say, I don't really know, but this sounds like runner's knee, sounds like a torn ACL, sounds like blah, 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 blah. Let's get an MRI to be sure. We'll get an MRI, and depending on the findings, yep, sure enough, there's something torn in there. We got to send you to an orthopedic surgeon, and let's get surgery and get that fixed. And so you're right. That's exactly the pipeline that we're talking about. Now, if the patient, and I remember having this issue, a patient came to me and said, I've got X condition. I can't remember what his particular condition was, but I said, I think it was low back. And I said, do you want an MRI? And he said, yeah, I do. And I said, okay. If we find something abnormal, when in your schedule can we fit surgery? And he's like, I don't want surgery.
Mm-hmm.
And I was like, so there's no way you would consider surgery? And he said, no way.
Right.
And I was like, then why are we getting an MRI?
Right.
Because from a non-surgical perspective, it's not going to change my management. He didn't have a clinical symptom that made me think he needed surgery immediately, like this was a surgical emergency. And so even like with a torn ACL, that you don't have to do surgery on that emergently. In fact, most of the time they'll let the swelling calm down anyway.
Right.
So why? I mean, if you just want to know, okay, that's one thing. But insurance doesn't often cover because I just want to know.
It's not a line.
That's right.
It is, but it's rejected 100% of the time.
Right, exactly. Now, in the military, we often got those because, if that's a torn ACL, torn whatever, then we need to know that because he may not be able to deploy, he may not be able to do his job, those kinds of things. So it led me off on this quest to better understand MRI and when should I best utilize them and, who should I get them on. Now, of course, we've talked about prolotherapy before.
Sure.
And prolotherapy changed the whole game for me. I mean, it literally changed my entire approach to musculoskeletal medicine because ligaments and tendons are a common source for a lot of musculoskeletal pain. And MRI isn't going to detect the cause of their pain. Now, the other thing that prolotherapy has changed for me is there is lidocaine in the solution. So if you come in and you say, I hurt in point A, and then on my exam, I find that it's actually point B, and I go to inject there. A lot of times patients are like, but I don't hurt over there. I hurt over here.
Right.
And we do that. And sometimes, a common one would be pain rate going down my arm, like into my bicep and down this way. Well, that's often biceps tendonitis, and I can inject that, and the pain, because of that lidocaine, goes away pretty much immediately. And so then I can directly correlate their symptoms with the location of their of the problem. Because of that lidocaine, it numbs up that spot. If I do one injection and numb it up and their symptoms go away, it pretty much has to be that spot. And if they're hurting from somewhere else and I inject that spot, then it doesn't impact that pain. So prolotherapy really changed my whole thought process on this whole thing. So I was getting patients that were coming in with a variety of conditions. They would say, I've got an MRI and it shows I've got a torn meniscus, or it shows I've got a torn ACL or a torn MCL or a torn fill in the blanks. And they recommended surgery. So I was like, yeah, but I just don't see that much of this. Let's do prolotherapy on it, see what we get. We did prolotherapy and they get better. And so started doing some research. And I found out that MRI wasn't at all what I thought it was. So just brief intro to MRI. It's magnetic resonance imagery or imaging. And basically you've got a very strong magnet that causes the hydrogen ions to spin or to vibrate. And they vibrate at different frequencies. And so the computer can put all that together and you determine these different densities and you get a three-dimensional picture of the structures. Now, an MRI is extremely sensitive, meaning that it will pick up any little thing. So the sensitivity of the MRI is very, very good, but it's not specific. In other words, it'll detect everything. It won't tell me if that's exactly why you hurt.
Right.
And that's the crux of my issue. Get MRIs on low backs, and you see these herniated discs.
Right.
You see all this stuff, but their clinical symptoms aren't consistent with that. So let's talk about some of the literature that's out there. And so the first one is a study that was done by Boos, B-O-O-S, not B-O-O-Z-E. This was published in 1995. He did a study of 96 patients that had absolutely no back pain and absolutely no history of injury.
Right.
And he ran all 96 patients through MRI. No pain, no previous injury. 76% of those normal, healthy, asymptomatic patients, 76% of them had disc herniation on their MRI. 17% had minor nerve root compression. 4% had major nerve root compression. Like, this is a big deal. We need to intervene. 85% had degenerative disc disease. And I get patients that come into my clinic and they say, on my MRI, I've got this degenerative disc disease. Holy cow, what am I going to do about this? And nothing, because 96% of the people, or 96
Right.
people had,
Right.
or 85% of the people had that on there, and they had no symptoms. So why? Why do you care? And then 13% had what was called a disc extrusion. That's basically where the disc has blown up and chunks of that disc are floating around in the spinal canal. And the disc, the jelly is leaking out. If you squeeze
Right.
a jelly donut,
Right.
and all I can think about is Private Pile. A jelly donut.
There you go again. Dr. Humor.
Exactly.
My dad was a minister. I'm used to like minister humor and Dr. Humor. It kind of all falls in the same category.
Yeah.
Yeah, we'll talk about it later. I don't want to offend you on the show.
You'll offend me later.
I'll offend you later.
All right. So anyway, there's a lot of abnormal findings, and some
Right.
of them can be severe on patients with no problems.
Well, it's interesting to me is, again, the common listener here is how highly sensitive they are. I didn't know how sensitive it was, and it can pick up every little thing, which is not
Yes.
necessarily
Exactly.
a diagnostic tool to say that there's always cause and effect, causality. I got a question, Marshall. Is there a technical guy here? He's an athlete. You can tell. Looks like a white Michael Jordan. His name's Marshall Mathers, which is Eminem. He's our tech guy here. So Marshall, seriously, have you ever had an MRI
I've never had an MRI.
in all your years of professional basketball?
In all my years of professional basketball, still no MRI.
Right. I actually, as handsome and as athletic as you look, I actually was an athlete. Right? Chad will tell you.
Yeah, he ran track.
Some people say that I was okay at track. I wouldn't be one of those people.
I think one of your records still stands.
Many, Chad. Many. I don't think it has anything to do with track, though.
When you say many, are you referring to the size or are you referring to the number?
Either. There's that. But I have had MRIs. And in my experience, the MRI was somewhat inconclusive in determining my result.
Right.
Or origin of pain.
Right.
Specifically to your point, when it's muscular in nature.
Right.
And I ripped my quadricep, for example. I was a sprinter.
Right.
And I got an MRI, and it originally they had thought probably it was some structural problem that had caused stress on the actual tendon, right?
Right.
And they never could find a solution.
Right.
And they didn't really ask a whole lot of questions. They just said, "Well, give you a shot in your leg, boy, and get back on that track." This was in the 90s,
right.
before Marshall was born. But but I've never had personally great experience as an athlete with MRIs. Me personally.
Right. I'm going to read this real quick. This was from a paper from the New York Times that was published in 2011. And they said, talking about MRI, they said it is a very sensitive tool, but it is not very specific. That's the problem. And scans almost always find something abnormal, although most abnormalities are of no consequence. It is very rare for an MRI to come back with the words normal study, said Dr. Christopher DiGiovanni, a professor of orthopedics and sports medicine specialist at Brown University. I can't tell you the last time I've seen it.
Wow.
And when I look at MRI results, I do not get them that say normal study.
Mm-hmm.
I do on CTs. You don't on MRIs. I've never seen it.
That's interesting. I think that's contrary to what most people would believe about MRIs.
And if you talk to a radiologist, all they're doing is describing what they see. They're not making a diagnosis.
We've all been there. What are you looking at on the screen?
Exactly. And they're just describing it.
They're describing it.
And
they're storytellers.
That's exactly right.
It's like observing a car wreck. I saw the car wreck.
Right.
Whose fault was it? I have no idea. This is what I saw.
So the problem is not with the radiologist.
Right.
Because they're doing exactly what they're supposed to do. The problem is in us interpreting the radiologist read.
Right.
Or even, some physicians will interpret their own MRIs. Orthopedic surgeons definitely do. And they may talk about it with the radiologist. But so if all you're doing is reading this report, then it's our responsibility to interpret that report appropriately. And how does this correlate with the patient? When I was seeing a lot of my patients with this low back pain, I would look at the results and they would say, you've got a herniated disc at the L4, L5 junction.
Lumbars.
With minor or moderate or severe nerve root compression, but yet on a physical exam, they've got none of those findings.
Right.
It's something very different. Or it's on the complete opposite side. Well, that's not the problem. They may have that, but that's not why they hurt.
Mm-hmm.
And I believe that's one of the reasons that surgery for low back in certain circumstances has such a poor track record. I think that's why low back pain in general can be very difficult to deal with, but yet with prolotherapy, it's very straightforward, and we can help a lot of those patients.
Well, let's just say this. Let's just weigh the options here. For me, if I have, let's say, lower back pain, and I'm looking at the options of surgery, which we've already said most surgeries are most MRIs are precluded by a surgery, right? So it's MRI surgery, right? So you mess up on a surgery, it's a surgery. I mean, there's a risk of death during the surgery.
Right.
There's a risk of infection during the surgery. There's lost time and recovery time. And let's say it doesn't work. That's a pretty steep price to pay, right?
Oh, no question.
Yeah. So let's say we do prolotherapy, which is a liquid injected into a spot.
Right.
As simple as I can put it, right? That has a high rate of alleviating pain in certain situations.
Right.
In the joints.
Right.
And that nature. So even if it doesn't work, there's not a high risk there.
Right. The former Surgeon General of the United States said, the nice thing about prolotherapy, if properly done, is that it cannot do any harm.
Correct. Yeah.
So the lead physician in the country.
So So the problem is, and again, this is definitely against the grain, right?
Right.
Against the grain.
That's awesome. This is definitely against the grain. The problem is most people believe, and most doctors believe, get an MRI. They are not conclusive. Based on those findings that are inconclusive, get yourself a surgery that may not work.
I think you said that very well.
Right.
I want to drive 2 more points home, talk about 2 more studies that address this issue. Article in the American Family Physician, AFP, 2012, on knee pain.
Hey, this is better than the booze reference.
You like that?
What doctor is going to bring a reference from booze? It seems contrary
I don't
to
make
health.
up the name, Brian. It's
Or what medical place is going to be named booze?
it's just a scientific fact.
That's right.
And that is a scientific fact.
Good one, Chad. I like it.
Hey, I'm trying.
Dr. Chad.
Yeah, that was challenge accepted. Okay, so I'm going to read this straight from that article. Several studies have shown MRI may identify signal changes that suggest a meniscal tear, so talking about the knee, when the meniscus is not actually torn. Other studies have shown that even when a meniscal tear is detected, it may not be related to the presenting problem or the presenting symptoms. Research suggests that a fairly high percentage of arthroscopic procedures may be performed based on abnormal MRI findings instead of clinical findings. I think they summed that up very well. Another, again, from that New York Times paper in 2011, they took pictures. I don't remember the number of them, but it says it in the paper. These pictures, no injury, no pain. MRIs performed on all of them found shoulder cartilage abnormal in 90% of them and abnormal rotator cuff tendons in 87%. The quote from the orthopedic surgeon that wrote this report said, "If you want an excuse to operate on a pitcher's throwing shoulder, just get an MRI."
Wow. This is what I love about this show. Who in their right mind would take on MRIs and surgery? But this guy, Dr. Chad Edwards.
I just want to do the best I can for the patients.
Right.
Let them get educated. If surgery is the best course of therapy, then by all means, let's do that. And you want to find the best orthopedic surgeon you can to do it. So I'm not anti that therapy, but we just have such a low threshold for get an MRI and go get surgery, and we got to break that paradigm.
I think it's interesting if you and I could Google it, but I'm not going to because we can just talk about it as what I think would be a matter of fact. If you look back through medicine and so many interesting things that were once thought true, that now all of us would say obviously is not true. I think of a couple. I remember reading articles about blood transfusions.
Right.
Right, in the 1910s or 20s, right, where they would literally either take out all of your blood, siphon it directly back into you, or they would put leeches on you to try to cure you of diseases. What other weird things have we thought in medicine?
You mean, well, not necessarily in medicine, but you mean like the world was flat?
Yeah, the world was flat, right? Those kind of things. But medicine is one of those areas that it needs to be constantly challenged, even in areas like MRI and surgery, right?
That's right. One day we'll talk about cholesterol.
Cholesterol is a good one, right?
That is a really good one.
I think that one is really making some progress in mainstream because I think people used to think, I have a cholesterol problem if I have a total cholesterol level of X, right? And so now they're finding that there's a balance of cholesterol and it's much broader than that, right?
Right.
Yeah. So that's one. Name another one that in your medical career, over the span of your career, that has kind of been at once time when you first started maybe was generally accepted. Now it's kind of like, okay, we don't accept it. Would it be cholesterol?
Well, there was one that comes to mind is that for acute high blood pressure, when someone came in and their blood pressure was through the roof, we used to give propranolol, and we take a little capsule and put it under their tongue. We actually found out that caused harm. The Women's Health, good grief, what's the name of that study? Is on hormone replacement therapy published
the Booz study.
No. It was published in 2002, I believe. Talking about hormone replacement therapy for women and how it was protective for cardiovascular disease. They actually stopped the study early because they found out that it was actually causing cardiovascular disease. And they stopped it early because there was so much harm that they couldn't continue the study.
Wow.
So we see stuff like that all the time.
Wow.
And prior to that, we thought that hormone replacement therapy was actually protective. There's some nonsense out there about red meat and cancer. The World Health Organization recently declared it a class 1 or a group 1, whatever, carcinogen on the same level as tobacco, based on zero sound scientific evidence. They're basing it off of some very poor epidemiologic associations that are uncontrolled with other risk factors.
Right. I think about one big one, because I want to talk about this only because when you do a show that says, hey, I'm challenging MRIs and surgery, that's a fairly big claim, right?
Right.
That's a fairly big claim. I was watching the show Concussion.
Okay.
I don't know if you've seen it with Will Smith. Marshall, you know what I'm talking about? The NFL.
Yeah.
Yeah. So I'm watching the show, and the basic gist of it is, and I think it's a perfect discussion around what we're talking about right now, is for years and years and years, the NFL has denied proof of concussions.
Right.
That football causes concussions.
Right.
And this movie is based on a true story about I think it's a Nigerian doctor that working in the United States
Right.
Did an autopsy on football players,
Right.
and found that there was a disproportionately high number that had brain injuries, life-threatening brain injuries, right? Distort their personalities. It's interesting in the movie how the medical industry flat out denied it in the beginning.
Right.
Not because there wasn't conclusive proof, because as we know now, there was.
Right.
It was because there is an establishment. And for an example, there is a large number of people, there are probably a few number of people that make a lot of money on MRIs.
Yeah.
And people need to understand that. And they have agendas, and they have profits, and
Right.
and they have probably some evidence that they like to claim that probably is true, but it's not true. It's not the best. And it's not the best and the consumer needs to educate themselves.
And let's be clear. I want to be very clear about this. If anyone, the physician included, if the physician is benefiting at the patient's benefit,
Right.
I'm all for it.
Right.
If the physician is benefiting at the expense of the patient, they should be shamed.
Right. That's great. That's a great quote. And so our system isn't set up in such a way, and I think the NFL is a great example of that, a great case study on it, that just because it's popular doesn't mean it's regulated the way it should be.
Right.
Right.
That's
and
right.
So I think I take away from today's show, as I do every show, and I'm so proud of you, I really am, for having the courage to come on a show like this and tell the truth.
Well, thank you. I got to sleep at night, and
Yeah.
the only way I can do it is to do the best I can to make sure that we're doing the best we can for the biggest number of people.
Yeah, I like to pick on you because you are smart and you are successful, right? And you need to be humbled, right? Daily.
Thanks, Brian. I
Yeah.
appreciate that.
But the thing I like most about you is you've dedicated your life to people, right? And I really think it can't be just about your practice and the amount of money you make. I think this show is all about purpose, right? The show, I heard someone once say, there's a difference between purpose and success, right?
Right.
And I believe you're living out your purpose, and that is to help people recognize that the simple things in medicine, like MRIs and surgeries, aren't the only option for them. And I think that's what you do well.
And Zig Ziglar said, if you help enough other people get what they want, you'll get what you want.
You know, I just said that the other day, and you ripped it off. I said that to you, and you used it on the show. There should be regulation on the show.
You think?
Right. There should be regulation on the show.
I should be fined.
But I do want listeners to know the fact of this show is it's not regulated. That is the truth. We're just two average schmoes here, happen to be highly educated, right? Which is a surprise to most people.
Well, at least we have degrees.
We have degrees. Yeah, I wouldn't call that education. That's a great point, by the way. Well, maybe we'll have a show about that.
There you go.
How little we actually learned, right? But I do think listeners need to understand that this is a show that's very organic, very much intended to help people, and profit is not the center.
That's right.
I think we.
I haven't gotten a paycheck for this.
I definitely haven't, and that's I feel I'm bringing so much to this show, right? I should at least get a couple $1,000s an episode.
Well, I thought it was just getting to hang out with me that was your payment.
Right. I met with Duck Dynasty a couple weeks ago. I really did, right?
Yeah, right.
And so they get paid for their shows. I found that out when I was there.
Right.
I'm like, this is new to me.
I believe they get paid well.
Yeah, that's what they were saying.
Yeah.
That's what somebody else told me.
Yeah.
That's kind of a joke. I'm just saying you should consider that. Payment.
For-
Then that would take away purpose, right?
No.
Take away purpose. No, it wouldn't.
No.
We're getting so sidetracked on this
Yeah.
show, and people just turned it off. But I do want people to know to stay tuned, because if you believe in purpose in medicine, if you believe that they somehow connect, I encourage you to stick with Dr. Chad Edwards and this show, and we appreciate you listening. We'll see you next time.
Thanks, Brian.
Thanks for listening to this week's podcast with Dr. Chad Edwards. Tune in next week where we'll be going against the grain.